Well, now I'll be discussing medicine question of Grand Test 185. Well, 219. Forced vital capacity is done to test which condition? The answer to this question is myasthenia gravis. Okay. Well, this is also, in fact, there are two answers in this question. Even this is also right answer. But this is better answer. Now let me just discuss this beautiful controversial question and why C is better than B or A also. First of all, why we check forced vital capacity in case of myasthenia gravis? This is to know how much strength is there in the respiratory muscle. And we all know very well that inspiration is an active phenomena and expiration is a passive phenomena. Right? So now we want to check the muscle strength, especially of the respiratory muscle. We go for FVC. Well, we all know very well that in case of myasthenia gravis, it's a type of only muscle weakness. And this FVC is especially useful in those cases where patient has myasthenia crisis. Or we want to follow up, or we want to say how much severity of the case of myasthenia, we go for FVC, right? So what about in Guillain-Barré syndrome? Well, in Guillain-Barré syndrome, we all know very well, in Guillain-Barré syndrome, there is an ascending muscle weakness. And this weakness is areflexic. Well, in GBS, especially you know very well that as it is an ascending type of paralysis, it may also involve diaphragm. Diaphragm also, which can lead to muscle weakness, and that can lead to respiratory problem. Patient can have respiratory arrest also. Well, we keep on monitoring FVC also in case of Guillain-Barré syndrome, but if needed, not in all the cases. So what I told you, that's why this can be used in two conditions, but it's definitely much better indication in case of myasthenia gravis as contrast to Guillain-Barré syndrome. Third generation inhibitor for CML is, the answer to this question is ponatinib. Well, we are all aware that in case of CML, there is ABL, BCR translocation, and this is mediated by the enzyme tyrosine kinase. Okay, that's why for the management of CML we use a drug, tyrosine kinase inhibitor. And the first drug which was introduced for this was imatinib. With the introduction of imatinib, the entire treatment of CML changed to a great extent. The cure rate was went up to very, very high percentage. Well, as the time proceeds, we get newer generation, and now you got third generation, that is ponatinib is the answer. Now I have a rank number one question. I talked to you regarding imatinib. Now tell me, what is the main dangerous side effect of cardiac side effect of imatinib? Stop the video, write down the answer. The question is dangerous cardiac side effect of imatinib. Well, I'm sure you've written the answer by now. The answer is it can lead, is one of the important causes of dilated cardiomyopathy. Okay. Now, other drugs which can lead to dilated cardiomyopathy are doxorubicin, cyclophosphamide, trastuzumab, okay, and cocaine also. Cocaine can lead to coronary artery disease, it can lead to dilated cardiomyopathy also. So the drugs which can lead to DCM. Question 221. All are true about adiponectin except the answer of this question is that it level increases in obesity. Okay, the level rather it reduces in obesity. Well, adiponectin is a kind of, now in our body, there are certain molecules which are occurring naturally. One is leptin, and other is adiponectin. These two molecules, this in particular and this also, they reduce, they reduce insulin resistance. Okay. Well, in these patients, this level are reduced, and now it is naturally occurring compound that we have in our body. Now all the pharma companies are trying to get a drug which can cause increased level of leptin and increased level of adiponectin. What will happen? Suppose we get one molecule, say ABC. ABC molecule is developed and this causes increased level of leptin and increased level of adiponectin. So what will happen? They will reduce insulin resistance, sugar will come down. As of now, there is no such molecule so-called ABC. Maybe down the line after 15, 20 years, when you become a teacher and by the time a molecule ABC will be there, anti-diabetic drug, then which will cause increased level of leptin and adiponectin, and insulin resistance will go down. Now, how will you teach that time after 20 years when you become a teacher? Well, you will teach like this. Well, nowadays we treat diabetes by molecule ABC. It acts by increased level of leptin and increased level of adiponectin, which reduce insulin resistance, sugar come down. Then you will add on to, after a pause, you will say, well, when we were students way back in 2019, we used to treat diabetes by metformin, sulfonylurea, blah, 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 and all these drugs are obsolete nowadays, okay. But you will say again, yeah, for first time, one gentleman, Dr. Bhatia, mentioned about leptin, adiponectin, and molecule ABC. That time, aapko meri yaad to aayegi, you will definitely remember me. As of now, this is a very, very important question, leptin, adiponectin. The reduced insulin resistance will be surely coming to you in this exam, is a VVIP topic. Well, 22. Include all except, the answer to this question is sotalol. Now, first of all, let's see what is this. We are getting, this is a classical ECG of Torsades-de-Pointes. Torsades-de-Pointes. It looks like that ECG is revolving around the baseline, twisting around the baseline in the Torsades-de-Pointes. And it always occurs to any condition which lead to prolonged QT interval. Normal QT interval is 0.36 to 0.44 second. Now let us see what are the causes of prolonged QT interval. Prolonged QT interval is in hypokalemia, hypocalcemia, hypomagnesemia, erythromycin, and class 1A anti-arrhythmic drug, or any other anti-arrhythmic drug which can lead to prolonged QT interval like sotalol, which belong to class 3, but it causes prolonged QT interval. Okay, so that's why these drugs, class 1A drug like procainamide and sotalol, they are known as pro-arrhythmic drug. Why pro-arrhythmic drug? Because they can lead to prolonged QT interval and they can induce arrhythmia like Torsades-de-Pointes And tau steady point is the highlight is prolonged QT interval more than 0.44 second. In tau steady point is the QT interval may be as high as 0.60 second also. Well, the commonest cause of, in actual practice, the commonest cause of tau steady point is hypokalemia. But it's a dangerous. This arrhythmia can go into ventricular fibrillation any moment. That's why the moment patient come, of course, you take a sample for potassium and calcium, but first thing is you give magnesium sulfate. It prevents patient going into ventricular fibrillation. Otherwise, we can even use pacing also. In some cases, the BP low, we can even use for isoproterenol also. But sotalol is definitely never used. Even isoproterenol is not a very ideal drug to use, but if I have to choose the answer, the best answer should be sotalol, not to be given. This is by mistake, the repeat question. It was a clerical error. I hope you will excuse us. Now, a 30-year-old complaint of the patient. The answer to this question is pituitary adenoma. Well, pituitary adenoma, high prolactin level is there, so rather we should say it's a case of prolactinoma. Well, before I discuss this topic, we all know, I don't need to tell you that prolactin is the one hormone which is concerned with milk in the breast. Now, let's learn the basic concept of milk in the breast. Well, in the hypothalamus, we have a dopamine. In the pituitary gland, we have prolactin. And this prolactin is under inhibitory control of dopamine. It is there, in fact, this molecule, this combination is there in all the normal human being, male, female of any age. Prolactin is under inhibitory control. But when the milk is needed, like in pregnancy or in lactation period, then this dopamine is reduced. Okay, what I can say in a lighter way, this is the handbrake, which is always there. That's why handbrake is there, the car doesn't move. When you need to move the car, you remove the handbrake and you start the car. So handbrake is there in all the cases, all the time. But when we need milk, that is, again I told you, in pregnancy lactation, this goes away. Now once the inhibition gone, more and more prolactin level in the blood, and that lead to milk formation. This is a basic physiology of milk in the breast. Well, now any drug or any condition which will be a dopamine antagonist will lead to increased milk, so-called galacturia. So any drug, dopamine antagonist will lead to galacturia, and in the treatment of galacturia, we'll be using dopamine agonists. And the commonly used drug which we use for treat galacturia is bromocriptine, and we also use cabergoline. Now I have a rank number 1 question for you. Bromocriptine is the one drug which I've been using for ages for Parkinson as well as galacturia. Now tell me, recently a new use of the bromocriptine has been introduced. What is that use? This is the rank number 1 question. Stop the video, write down the answer. Well, by now you've written the answer, I hope. The answer is now it has been approved as a anti-diabetic drug also. Now question can be asked to you this way also. Which of the following anti-Parkinson drug reduces blood sugar? The answer should be bromocriptine. Question can be asked to you in this format also. Well, question 225. It's a lovely clinical based question, the new pattern question, which is going to come in your NEET and AIMS exam. The answer to this question is heparin. Unfractionated heparin is the answer. Well, it's a case of acute pulmonary embolism. How do you know? First of all, sudden onset of breathlessness is the key. And in nephrotic syndrome patient, these patients are prone to increased clot formation. Okay? And he had after air travel club. Whenever you get a question like air, prolonged air, and patient has sudden dyspnea, this is pakka pulmonary embolism. Okay? And tachycardia is a feature, classical feature that we get in. But fortunately, BP is maintained, oxygen saturation is reduced, and echo finding also confirm that there is right ventricular dilatation with interventricular septum shifted to left. All these findings are indicator of pulmonary embolism. Well, the patient of pulmonary embolism come, the first thing is to start heparin therapy. Okay, it's an immediate step. This we can do in the emergency room also. Okay. Now, intravenous plasminogen activator, it is just like thrombolysis. Cannot be done in a routine ward. Thrombectomy done in ICU setup only, and IVC filter R is a late thing. So what he is asking, what is the next best management? The next best is undoubtedly is heparin. Okay. Now let's talk something more. Tachycardia is the most common in ECG. In pulmonary embolism, most common finding is tachycardia. Most classical finding in ECG, characteristic finding in ECG. In ECG S1, Q3, T3. That means in L1 you get a deep S wave, and L3 you get Q wave and you get T inversion. Downward arrow means inversion. And now rank number 1 question for you. Stop the video, write down the answer. Tell me which other paradoxical finding can be seen in a case of pulmonary embolism in ECG. Which finding paradoxical? Stop the video, write down the answer. Well, I'm sure you must have written the answer. The answer is bradycardia. It is true that tachycardia is the most characteristic finding, but we should not forget there are few patients where even bradycardia can be seen, and that is known as paradoxical bradycardia. Question 226. Okay. And oligoarthritis there and fleeting opacities are seen. This is seen in venous granulomatosis. Okay. Well, fleeting opacity can be seen in ABPA also. It is seen here also. But in this, in ABPA, usually oligoarthritis is not a feature. It is seen in venous granulomatosis as a feature, right? So regarding venous granulomatosis, is a type of vasculitis, type of small vessel vasculitis. The classical triad is upper respiratory tract, lower respiratory tract, which can lead to hemoptysis. And this can lead to some nasal polyp. And patient has renal involvement. Renal involvement. In the renal involvement, classically what we see is crescentic glomerulonephritis. And in this patient, C-ANCA antibody are positive. Okay, and these antibodies are directed against proteinase 3. Treatment is corticosteroids. Okay, now again rank number 1 question. Tell me in what, now suppose there is one patient of venous granulomatosis. Patient come and sit in front of you, just tell the history. The moment he starts telling the history, you diagnose he's a case of vaginous. What are the findings that you are looking at in his face or mouth, whatever you want, which points that you are dealing with vaginous granulomatosis? Rank number 1 question, stop the video, write down the answer. The answer is, in this patient you get strawberry gum. Strawberry gums are the classical finding that we see in vaginous. The moment the patient comes sit, he's open the mouth, you can diagnose he's a case of vaginous granulomatosis. 227. The answer to this question is hypoventilation. Okay? Well, he has the right heart failure and he has the respiratory acidosis. The gradient is normal. And this is seen in those conditions where we have type 2 respiratory failure. In these three, you get type 1 respiratory failure. Now, let's talk about how to differentiate between the two. Well, we call as normal PaO2 is 94 to 104 millimeter mercury. For easy calculation, I take 100. Now I tell you the basic concept about the respiratory failure. Whenever PaO2 is below 60, we call as respiratory failure. We have type 1, we have type 2. PaO2 less than 60, less than 60. PaCO2 less than 40, more than 45. And PaO2, this A for, capital A for alveolus. PaO2, small a is arteriole. This gradient is increased in type 1, normal in type 2. Like in our case, we are getting, in hypoventilation, we get type 2 failure. So gradient is normal. In all the other three conditions, the gradient was increased, so they are type 1 failure. So I hope you got the answer. Why? The answer is hypoventilation. And of course, in hypoventilation, one of the classical feature is respiratory acidosis. Question 228. This is really a very tricky question. The answer is this one. Normally, we are all taught that in a case of aspirin poisoning, it is metabolic acidosis with respiratory alkalosis. This is true. Undoubtedly, there's no doubt about it. Now, what happened? Classically, in case of aspirin poisoning, most initially it is metabolic acidosis. This to begin with. Why? It is salicylic acid, so this leads to metabolic acidosis. And now when the compensation starts by hyperventilation, the patient develops metabolic acidosis with respiratory alkalosis. But in the very advanced stages, when the patient has got total fatigue, exhausted, then even respiratory rate goes down. Now, patient develops metabolic acidosis with respiratory acidosis. Now, if you look into question 1 again, he says very late state, categorically he said about aspirin poisoning. So hence the best answer, right? Well, what about other thing? We look into ventilation stimulation, it occurs. Alkalosis never occurs, and this may occur in some patient. But however, this is the best answer. Again, a controversial question for you. 229. The answer to this question is trimethoprim. Okay, why this answer? This, if you look into this thing, there is consolidation is there, and creatinine is 1.6 now, and 3.8 on day 4. Even potassium has gone very high. WBCs are there, right? Now, if you look into this thing, patient has gone to renal failure. His creatinine is high, potassium is high. This is a drug induced, and this sulfur drugs are notorious to cause interstitial nephritis. And the whole problem is within 3 days, 4 days. It's a short history, and there's no cast. No cast. That means it's not due to pyelonephritis, but there are WBCs, and the no RBC. That means it's not a glomerular disease at all. And now, extra question: what type of WBCs are these? These are eosinophil. Eosinophil. Suppose in the question they mentioned about eosinophil, then there's no doubt about it, 100% we are dealing with interstitial nephritis. Okay? Well, in interstitial nephritis, the basic problem is impaired reabsorption. Okay, impaired reabsorption. Why? This is the nephron, and we are well aware that this tubules and interstitium, they together, they reabsorb water and electrolyte. 180 liter is filtered of the urine from glomerulus, 178 is reabsorbed, only 2 liters go out. And that's why at time in interstitial nephritis, typically in chronic interstitial nephritis, patient may have impaired concentration ability. And that's why in case of chronic renal failure, what we get is isothinuria. Isothinuria means impaired concentration ability. Now a rank number 1 question. This is seen in chronic renal failure due to whatever reason it may be, impaired concentration ability. The question is, tell me in which hematological condition we get isothinuria. Rank number 1 question. Stop the video, write down the answer. So by now you must have written the answer. Answer is sickle cell trait. In sickle cell trait, not in anemia, patient has the only problem what the patient can have is impaired concentration ability, what is so-called isothinuria. Rank number 1 question. Non-functioning adenoma, most of the time it is usually due to gonadotropin producing cells. Well, if the excess of prolactin is there, that may produce galacturia. If ACTH producing, this is what is so-called Cushing disease. So-called Cushing syndrome. Cushing syndrome is due to excess of steroid hormone. It can occur from ectopic secretion of ACTH. It can also occur from adrenal adenoma or carcinoma. It can also occur from exogenous steroid. All these are known as Cushing syndrome. Okay, Cushing syndrome is due to anything which lead to increased steroid in the body. But when we say Cushing disease, that means we are talking about excess of steroid because of ACTH producing cell. The Cushing, what we call a Cushing disease. The Cushing disease is a type of Cushing syndrome, but all Cushing syndrome are not Cushing disease. And TSH producing cell, they will produce secondary hyperthyroid. In this case, there will be increased TSH, increased T3, increased T4. Okay? This is regarding secondary hyperthyroid. Well, we got beautiful colored pictures. That means we are getting colored urine. Colored urine is seen in rifampicin, entacapone, and phenopyridine. Cimetidine is not a cause of colored urine. particularly in this, because it's most widely used drug, much more commonly used drug as compared to other drug, and this we use for tuberculosis. Okay, so whenever you prescribe rifampicin for any patient, particularly for tuberculosis, you should not forget that you will be passing the red color urine. If you do not say the patient passes red color urine, and the very morning he will call you, he'll say, doctor, I'm passing red urine, I'm passing blood. But it's a physician duty to tell the doctor or the patient that red color urine will be there. Well, we use rifampicin. Now, extra edge question for you. Rifampicin we use for meningococcal prophylaxis. This we know, meningococcal prophylaxis. But some of you are not aware that it is also very, and the rifampicin is a very good anti-staphylococcal agent also. We use for staph also. And now come the rank number question. We also use this drug to control itching in primary biliary cirrhosis. These are the rank number 1 questions are there. Okay. (232) diabetic skin pigmentation cardiomyopathy. What are the best initial tests? Well, in this again we have controversial question. We have 2 things to do. We can go for iron binding chemistry also on serum ferritin level also. But this is a better answer. Okay? Rather, even better than this was transferrin saturation. This is the best answer. This is second best. This is third best. These 2 we do for Wilson disease. But what the condition is a cirrhosis. What the condition is? Pigmentation. This is hemochromatosis. Primary hemochromatosis, and which lead to this problem. And this excess of iron, and they are lead to restrictive cardiomyopathy as well as diabetes with cirrhosis, so-called bronze diabetes. Bronze diabetes. Now, something very unique and special thing. Here, hemochromatosis is the iron overload state. What is special thing about? Now, what happened to RBC count in these cases? RBC count increase, normal, reduce, or any of the above can happen. Stop the video, write down the answer. The question is, what happened to RBC count? Is iron overload state. What happened to RBC count in this condition? Increase, normal, reduce, or any of the above can happen. Well, the answer is normal. While there are 100 causes of iron overload state, the only condition where RBC count is an iron overload stage with increased HB. Increased HB with iron overload state is seen in plenty of conditions. The only condition where increased HB with increased HB with increased ferritin with normal RBC count is hemochromatosis. And now come the rank number 1 question. Tell me any other disease which is not related to hematology at all, which can lead to iron overload state. Okay, the answer is alcoholic liver disease. Alcoholic liver disease is again a iron overload state. Rank number 1 question. Question 233. The answer is carvedilol. Patient has heart failure with dyspnea. So potassium level is and creatinine is high. In that means patient has CRF. In CRF we do not use spironolactone. Potassium level is already 4.5. If we use it, may further increase potassium, which could be dangerous. Enalapril again is the one drug we never use in CRF because this is one drug, ACE inhibitor, it can lead to hyperkalemia. Same for digoxin also. In chronic renal failure we do not. In fact, these are 3 drugs that we don't use in renal failure. Carvedilol is the one drug that we can use very safely in renal failure. Now, extra edge. Carvedilol, one more thing, there are only few drugs now you are well aware that beta blocker can be used in CHF. Now, what are the beta blockers which have been approved? Only three. One is carvedilol, and second one is metoprolol and bisoprolol. So we have a drug. We can use in CHF with the indication of using CHF carvedilol. Another three drugs are contraindicated because of chronic renal failure. So undoubtedly the best answer is carvedilol. 234 is a case of grave disease. Why grave disease? Because we are getting plaques. Okay, look like, what look like? Like orange peel. That we see in grave disease. Remember, grave disease is a triad. It's a triad. It's an autoimmune disorder. Triad of hyperthyroid, dermopathy, and ophthalmopathy. In dermopathy, we can also get clubbing, what is known as thyroid acropathy. Okay? And this entity, orange peel appearance, this is known as pretibial myxedema. It's not myxedema. Myxedema is seen in hypothyroid. He's talking of pretibial myxedema. Is a very frequently asked question. What is the diagnosis of this case? This is a case of scarlet fever. How do you know? We get, in this case, we are getting strawberry tongue. But this can be seen in Kawasaki disease also. But we are also gash, slap, pattern rash. That is classically seen in scarlet fever. But in the exam, Kawasaki disease is much more frequently asked question. Kawasaki disease is a very VVIP topic. So Kawasaki disease is a type of vasculitis. Classically patient, it occurs below 5 years. Again, if commonly asked question. Patient has fever, hepatosplenomegaly, H for hepatomegaly, S for splenomegaly. There are also lymphadenopathy, even lymph node are enlarged. And in this case, classically you get strawberry tongue. And what the classical finding that we see, invariably this question asks, they have coronary arteritis. And the child can develop myocardial infarction. So whenever they talk about a child getting MI, think about Kawasaki disease, treatment is immunoglobulins. Question 236. Okay. Diarrhea, anemia, raise enzyme. The answer shall be anti-endomycin antibodies. Now, what a clinical anemia is there? This is seen in celiac disease. In celiac disease, patient has a so-called allergy to gluten. And gluten-containing food are mnemonic is bro, barley, rye, oat, and wheat. These food elements are not to be taken by the patient. And remember, again, celiac disease is an autoimmune disorder. What a special thing, it's a T-cell autoimmune disease. Normally, most of the autoimmune diseases are B-cell, but it's a T-cell autoimmune disorder. And in this case, you can go for anti-endo. Best screening test is anti-endomycin antibody or anti-TTG antibodies. TTG antibodies stand for anti-tissue transglutaminase antibodies. Okay? But if they ask you, most confirmatory test is biopsy. And there are certain special associated condition in celiac, type 1 diabetes and dermatitis herpetiformis. These two are strongly associated with the case of celiac disease. And since diarrhea, and this is very common, that's why the other name of celiac disease is diabetic diarrhea. Diabetic diarrhea. Now, a question comes to you, why these patients develop anemia? This is due to reduced iron absorption. Why? The celiac disease is a disease of proximal ileum. Proximal ileum. And from the proximal ileum only iron and folic acid are absorbed. So these two are deficient. And in fact, what they call it, this is iron resistant iron deficiency anemia occurs in this patient. Now I have a question for you. Stop the video after listening the question and write down the answer. The question means, tell me any kidney disease where patient develop iron resistant iron deficiency anemia. Rank number 1 question. Stop the video, write down the answer. Well, the answer to this question is nephrotic syndrome. In nephrotic syndrome, transferrin is filtered in the urine. It's this molecule which absorbs iron. So that's why in nephrotic syndrome also you get iron resistant iron deficiency anemia. Question 237. The answer is C. We are getting a lady. Okay, she has a vegetation and both sides mitral, okay. Now this vegetation are nothing but a type of Lippmann Sachs endocarditis, which are very commonly to occur in SLE. Now, these antibodies are not due to any infection, but due to hypercoagulability. And this is due to anticardiolipin antibody because they have a EPLA syndrome. Anticardiolipin antibodies, EPLA syndrome. Here, PTT is prolonged, PT is normal, and they may have false positive VDRL tests. Okay, hence the best answer to this question shall be C. Well, 238 potassium level. Okay, we are using loop diuretics. They are known to cause hypokalemia, and hypokalemia precipitate digoxin toxicity. So in this case, definitely hypokalemia you have to manage by, you have to take care of the potassium level. Now there's certain beautiful question. We are talking about digoxin toxicity. Now what are the common arrhythmia that we see in digoxin toxicity? By Gemini. This is common arrhythmia. Which arrhythmia is most characteristically seen? Non-paroxysmal atrial tachycardia. with variable block. And which arrhythmias are never seen in digoxin toxicity? Never seen are atrial flutter and type 2B block. These two are never seen in a case of digoxin toxicity. Very frequently asked question. 239. This is acute cerebral hemorrhage. Sudden onset of gait unsteadiness and vomiting, headache. This indicate drowsiness. This indicate raised intracranial pressure. Sudden onset, remember in neurology, if something happens suddenly, is always vascular phenomena, unless proved otherwise. Now, raised ICP occur in bleeding, usually not in ischemic stroke. Now we are getting unsteady gait, that is will seen only in cerebral disorder. And why vomiting, headache? Due to raised ICP. And increased drowsiness, again raised ICP. And raised ICP is occur very quickly in posterior fossa lesion. Posterior fossa lesion. Why? It's a very close, brain is a very closely packed chamber, and posterior fossa is a very small chamber, and that's why raised ICP occurs because of bleeding. There is even compression on the CSF flow system also. So there is blockage to CSF flow also, and that lead to sudden increase in raised ICP. What is to do in this case? Urgent CT scan, plain CT scan, and do the surgery. Remember, cerebral bleed is the only bleed in the brain where we can, of course, in the parenchymal bleed, where we can operate. Of course, we can operate in meningeal like extradural hematoma. We can operate at extradural hematoma. We can operate at subdural hematoma. But they are in the meninges. But this cerebral bleed is a parenchymal bleed. The only parenchymal bleed that can operate, where we can treat, do surgery, is cerebral hemorrhage. Why? Is the posterior fossa, just make a cut at the back, take out the blood. Well, question 240, we have a patient of CAD who is using warfarin, okay, and you find that his eyes are about to left-sided weakness and eye depth to right. Again, sudden onset of focal deficit is a case of stroke. And stroke, remember, in any case of stroke, the first investigation is always CT scan of the brain. It is always plain CT. Plain CT of the brain is the first. Okay, why? Why plain CT? Because plain CT has much best way to pick up acute bleed is by plain CT scan, right? But remember, in case of 80% of the stroke are ischemic, only 15 to 20% are hemorrhagic. And the first 24 hours, even plain CT scan cannot pick up the ischemia, but it can pick up bleeding very fast, better than MRI. So we do CT scan to rule out hemorrhage, not to pick up ischemia. If there is no bleeding, we are sure that we are dealing with ischemic stroke, and we can start anti-ischemic treatment like aspirin. Okay, MRI is the best, next best. EEG we do only in case of epilepsy, and this we do only when patient has carotid artery stenosis. So this is all about the medicine question for this grand test, but in addition I have certain more information for you. Medicine e-Gurukul by Dr. Mukesh Bhatia, that is by me. What is this? Special feature of my app. I have got a recorded lecture of complete medicine in the way I taught you. Now, it is the best medicine app available in the market today. Why so? Every topic I have started with basic concept and gone to depth of topic. Latest updates are there. Lots of pictures are there. Discussion on the new pattern questions are there. Cover all allied subject also. I covered at least 13 to 14 question subject. And in the coming NEET and AIM exams, 70 to 90 questions will come from my app. It's so beautifully made. each video is about 20 minutes, so it's very easy to watch also. And at the end of each chapter, I have given LMRP, that is last minute revision point. That means a day before the exam, you just go through entire LMRP. Whole medicine you will be able to revise in just 30 minutes. Before the exam, you can revise in 30 minutes. 30 minutes, 70 to 90% questions, not a bad bargain at all. Now, how you should use this app now, as exams are quite near. You keep on reading whichever subject you are reading as per your schedule, don't disturb that. You see one video of my app, which is of only 20 minutes per day. 20 minutes you can very well spare in one day. From your daily reading of 20 minutes, you will be getting 70 to 90 questions. Remember, a single question done right or wrong can change your result. Not a bad bargain. Okay. How to get this app? Visit our website, dbmci.com, and look for Medicine eGurukul app by Dr. Mukesh Bhatia. Well, in addition to those who want to read text, is the Medicine Simplified Mini Harrison. It's a summary of 20 edition of Harrison. Reading one page of Harrison need half an hour. To understand, half an hour we need to read one page of Harrison. You need 2 hours to understand one page of Harrison, but you need only 2 minutes to forget what is given in that page. Harrison is the ultimate book of medicine, there's no doubt about it. But at this stage, you cannot read Harrison. You need something summary, so I have mini Harrison for you. It's the most best selling book in the market. And Medicine Essence Question Bank, again based on 20th edition of Harrison. Both are available on Amazon also, or we can visit our website also. Well, we can very well join at my Facebook forum, Dr. Bhatia Medicine Forum. Details are given. Join me so you remain updated for the whole thing. Okay? Well, thank you very much for watching this video. Thank you very much.